supervisors. So it's a really interesting partnership that we're hoping we can build on from there. And I want to talk to you today about health informatics, primary care going towards and in EHRs. And he said to me, so what have you been doing? I said, I've been talking at an event. And he said, I presume you're talking about hospital servers and software you should be using for people. And it really resonated with me because that's exactly what health informatics is not. It's not about those things. It's about a different thing. Not what it is. I just want to tell you what my premise is for what it is. And my favourite definition comes from a guy called David Penniman, who used to be Dean of the School of Informatics and People, which I really, really like. And so for healthcare, it's that intersection applied to solving problems in health. So how can we use those things, technology, information, we were talking about. And if you look, the progress we've made, so again on the horizontal axis, that's life expectancy, and on the vertical axis, creaking health economies to actually deal with the scale and change of this problem. And they break down into two nice categories, and these are the problems ideas. And the first one is that service delivery is becoming ever from clinical pathways really that we expect. And you can see how it started to get complex. And we mentioned again yesterday that we have got a serious rise in long-term conditions and care services, are they living in a rural environment, or living in an urban environment. And actually there's a great deal of research and a great deal of evidence that the local context of an intervention is exceptionally. We've already gone through an enormously complex pathway just to get to this point. And this is difficult, and this is just for diabetes, so if you're a multi-morbid patient, there's many, many of these. And the cognitive burden to take patients from a lot of those services, and then right at the top of the tree we've got acute hospitals who have links into hundreds and hundreds of these practices. So we've got this really diverse, our technical ability, big data, Hadoop, these kinds of technologies, or anything to do with miniaturization. You have Moore's law to thank. So this is George Moore working for Intel in 1960, integrated circuit every 2 years, and that has pretty much stayed true forever. And this means that we have started, we can get smaller and smaller applications with more and more power. We saw a best practice program, which we didn't invent, it just happened organically and started to spread. And the idea was that a group of GPs in the locality didn't want to set a record, and because they've got those information links, they could do that. So they did what we would call an e-consult. So the GP, instead of referring the patient, just refers the record, scoring the patient, giving them a frailty index, so a score really between 0 and 1, as to how vulnerable they were, based on the clinical, social, and financial. It's kind of small, I apologise, but on the left-hand side, the green line is the fit people, the people that the record identifies as not having a. On the red line, if someone's in that category of frailty, then there's almost a 75% chance they will die within 5 years, which does make a difference to how you plan for the components they need, but not necessarily with being able to code, because maybe you don't need that. So we've given people the ability to build that tool into the system and use it in whatever way they want with Europe. How do we start to catch up with what's going on in the UK and the Western world? And I think the answer is that you don't need to. I think you should be mistakes we've made, and starting from where we are now, which we've made some mistakes in terms of health informatics and technology, and starting with a brilliant canvas on which to work with that care. The one thing that I absolutely and utterly know is true, that whatever we're doing to treat those two problems we've talked about, it's going to need information and data, it's going to need technology. The next generation of healthcare, it's going to need the people in this room to help drive that through. And with that, thank you very much.
Evaluation means different things to different people. The process and reporting of evaluation, which will not be also useful to inform decision. So that's why it has to be done in a very should be repeated, and mistakes should be avoided. If you don't learn from what we have been doing, we will repeat them again and again for years to come. All the meticulous procedure will lead us to improve what has been done before, because there are often times when evaluation is performed. Evaluation seeks to answer the 5W and 1H aspect. Okay, so less complicated and useful. Now, depending on the purpose of conducting the evaluation, okay, we can decide on the in a few minutes. And as you can see that this dimensions influence one another, either one way or two ways. And this, then the depth is going into the 4 measures only instead of many other measures. So again, the selection, NHS care, primary care organization, followed by a systematic review, qualitative systematic review on 55 case studies. Realize that these factors, barriers or enablers, maybe we don't take time to learn, where they have very misaligned between clinical process and systems. The systems are not used, they are being rejected by the challenges and problems faced by this hospital in adopting CCIS. Now, actually the illustration helps us to unfold and understand. In the beginning, but I will stress this again, evaluation is very important to justify the value of HIS. It is not easy, but it is possible.
Informatics, Austrian Institute of Population, Health Sciences and Informatics, the University of Edinburgh, United Kingdom.
Digitized electronic health record-derived data for population health research, and just give you a bit of context. I lead the Centre for look at quasi-experimental studies when we're trying to evaluate health policy interventions and think about how we can begin to scale up and increase the efficiency, particularly related to quality. And as you can see, the UK figures particularly highly in this respect. It comes out, overall very well over a short time period, across the whole of England. So this was using population records, and as you can see, there was a correction, so this was fairly conclusive. But without a genuine population-based infrastructure, this kind of work or that clarification would have been completely impossible. What we were able to see here was that consultation rates remained high in those with a diagnosis of eczema over the life course. We were then able to attribute costs with you of what we've done in relation to asthma variation. So you can see that there are vast variations by ethnic group in the risk of hospital admission and mortality as a result of this. So a very dramatic effect studied at scale by looking at 10 million births over a really. So we recently also had the pandemic influenza, and what we did is that policy was rolled out, so interventions were rolled out in real time. We linked our data with how many patients we needed to screen. So over 300,000 patients to randomize just shy of 300 patients. Now you can only do this informatics capability. So this involved randomizing over 500,000 patients, a big cluster randomized controlled trial, but all of our outcome measures, these were, for example, beta blockers being prescribed to those with asthma. And you can only do these big cluster randomized controlled trials if you are using routine data. We used a comprehensive cohort design. So what we wanted to do was evaluate secular trends. So we took millions of patients who were evaluated key outcome measures. So for example, those being prescribed non-steroidal anti-inflammatory drugs with a history of peptic ulcer disease without. We have over 100,000 patients who have signed up to this. You can go to the website, have a look at this. There's a very great short video on this. Our target is 1 million patients. Really downloadable from the Institute of Medicine is really the benchmark for this idea. And what we're trying to do in the UK is to try and institute a learning at scale, and there's very large, so there's about to be £100 million investment in this initiative because the UK sees this as a project. And what you need to do really, policy-wise, is really strategically align your thinking and any pronouncements and suggestions you make with that. Develop are potentially your next liquid gold assets. This is an area where there's going to be enormous job opportunities in terms of data processors. Have a plan that is in place, but at the moment still much of your frontline staff do not have capability. Riyadh, Makkah, I've been to lots of cities, seen lots of centres, and there's a Ministry of Health plan in place, so I think you should put pressure on your government, it's quite reasonable. Don't wait for perfect. Don't wait for the Lamborghini plan, just begin with implementing a basic plan and then build from that. And the third is
about analytics and complexity of analytics. how do we transform? And I'll give you some examples of how we transform. We transform more and more patients, preventing patients from going into the disease complexity from primary, secondary, and tertiary through population health. Instead of episodic care, we create clinical pathways to take care of the patient from the beginning of the disease to the end. And we need to look into the causes of data, where it's secure, anonymous, and relevant to healthcare provision, so population data. Now here's what we did at KMC 3 years ago. Driven by data and guided by patient experience. We want to compare ourselves to the rest of the world through the global comparative. Specialized clinic, patient's home, transportation modes, a medical city or a highly specialized hospital, and a chronic care hospitals, and the general hospitals, the primary care centers. They're all scattered all over the place.